Hi everyone, my name is Sherene Loi and I'm speaking to you from the Peter MacCallum Cancer Centre in Melbourne, Australia. I'd like to thank the organising committee for the opportunity to speak to you all today, even though it's virtual, and I hope to be there next year. I'm going to start my video. So today I'm going to discuss the treatment of residual disease of triple-negative breast cancer post-neoadjuvant immunotherapy and chemotherapy. So these are my disclosures. So as background, everybody knows that neoadjuvant PD-1 inhibition or pembrolizumab with chemotherapy has recently been approved in early stage triple-negative breast cancer. Whilst this is the only agent that's been approved, other smaller studies also support the use of these agents, that is immune checkpoint inhibitors of PD-1, PD-L1 in the neoadjuvant setting with chemotherapy. Is there a biological rationale to administer these agents in the neoadjuvant versus adjuvant setting? Well, we only have this preclinical study to guide us, but it does make good biological sense that giving an immune checkpoint blockade with the tumor in situ would result in longer survival. And certainly this is what these investigators published in using their preclinical models, that the neoadjuvant PD-1 inhibition versus adjuvant inhibition resulted in improved survival of these mice from their tumors. And this was a result of greater antigen creation. So when the tumor is in situ, there's greater antigen diversity that's created. There's higher quantity of tumor-specific T cells that are produced. The presence of the tumor results in greater expansion of these T cells, and the T cells are more functional after tumor removal. On a practical sense, of course, administering or doing a study in the neoadjuvant setting is a way to accelerated approval. So I'm going to give this table, describe this table, which is a summary of all the neoadjuvant PD-1, PD-L1 trials that have been reported. So the KEYNOTE-522, which is the largest of these studies, used pembrolizumab, an anthracycline, taxane, and platinum-based chemotherapy backbone. With relevance to this particular talk, in the adjuvant setting, pembrolizumab was given or placebo for a total of 1 year. There was no capecitabine in this study. The PCR endpoint has been reported as positive with an increase of 7.5%, so from 56 to 63%. And recently, as everyone knows, the event-free survival analysis was reported as also statistically significant in favor of pembrolizumab with a hazard ratio of 0.63, so just under 40% reduction in events. The Impassion 031 was with atezolizumab, a smaller study with a PCR endpoint. This used the chemotherapy regimen of anthracycline with nab-paclitaxel. There was no platinum given. And importantly, atezolizumab was continued post-operatively or observation, and capecitabine was allowed for patients with residual disease. This was reported as a positive study in that the PCR was increased by a delta of 17%, so from 41 to 58%. And at the very first, very immature analysis of event-free survival, this hazard ratio was in favor of atezolizumab. The NEO-TRIP study was a smaller study, also with atezolizumab. This used a 24-week regimen of nab-paclitaxel and platinum. There was no anthracycline. In contrast to the other studies, anthracycline was allowed to be given post-operatively. There was no immunotherapy post-operatively. This study was reported as statistically significantly negative for the PCR endpoint with a delta of only 3%. The event-free survival results, which was actually the primary endpoint, has not yet been reported. And finally, the JAPA-NUEVO study was the smaller study. This looked at the benefit of the addition of durvalumab. This used a similar backbone to Impassion 031, which was nab-paclitaxel followed by anthracycline. There was no platinum. Here, of note, there was no post-operative immunotherapy given, and adjuvant treatment was as per clinician discretion. This was again reported as a statistically significantly negative study with a delta of 9%, but you can see the advantage of a larger sample size because this delta of 9% was reported as non-significant compared to the KEYNOTE-522. Of note and consistent with the keynote data, the hazard ratio was reported as in favor of durvalumab at a median follow-up of around 4 years, with a risk reduction of over 50% for breast cancer events. So if we look at the differences in the patient characteristics of these 4 studies, we can see that the NEO-TRIP is an outlier with higher stage disease. For example, here only 13% were node negative and 40% were T3, T4 and above, compared to the Gepinuevo study where the majority are T1, T2 and node negative. Keynote 522 in patient 031 were roughly similar with regards to the distribution of T1, T2. And there was around half were node negative, node positive in Keynote 522, whereas the majority was node negative in Impassion 031. And this is, of course, may be relevant to the hazard ratios and the better hazard ratio seen for Gepinuevo. Perhaps this was because there was lower burden disease. So let's look at the Gepinuevo, and these are the event-free survival outcomes according to PCR and residual disease. And you can see here that if you had a PCR and received durvalumab in pink, you had 100% overall survival, 100% free from distant recurrence, and there were around 2 events with the invasive disease-free survival endpoint, but these must have been local regional events because these patients all survived. So if you achieve PCR with durvalumab, you do really well. In contrast, if you have residual disease and also received durvalumab, you are doing better than if you did not receive durvalumab in the Navy. And you can see here, there's quite a significant difference. And particularly for overall survival, if you had residual disease and received durvalumab, your survival was as good as patients who had PCR and did not receive any immunotherapy. Of note, patients who had PCR in the light pink with durvalumab and the blue, which was placebo, there does seem to be quite a difference with regards to the events. It looks like there's roughly 10% difference at this point of 4 years follow-up. And even at 3 years follow-up, there does seem to be a major difference. And this is in contrast to the Keynote 522 data, which we'll be seeing shortly. So the Keynote 522 data, you can see here the event-free survival outcomes for PCR and residual disease. So as I've highlighted before, patients who achieve PCR do very well. In this study, the difference is not as marked as seen in the German study with regards to the addition of pembrolizumab compared to placebo. But of course, we don't yet have the outcomes for the distant disease-free survival and overall survival, given that the follow-up here was around 3 years. In contrast, the residual disease, you can see again that there is a significant improvement in outcome for patients who had residual disease and received pembrolizumab. And you can see here that, despite this improvement, of course, over 30% of patients are relapsing at 3 years. So this is consistent with the German data. And actually, if you have a look at the hazard ratios and the absolute benefits according to the total population, it's very, very similar to the German data. So we can conclude that neoadjuvant PD-1, PD-L1 inhibition gets more patients to PCR, and probably the quality of the PCR is better in that there's improved survival. And in patients with residual disease, the administration of neoadjuvant pembrolizumab also improves events-free survival for those who do not achieve PCR. Of course, in the Keynote 522, we have immunotherapy both preoperatively and postoperatively, so we actually don't know the contribution of each different part of administration. However, in the German study, the administration was all preoperatively, and given the results are very similar to the 522, it does suggest that perhaps the majority of benefit achieved is in the preoperative setting. And certainly those patients in the German study did not receive any postoperative durvalumab, and you can see how excellent or 100% overall survival and distant disease-free survival, bearing in mind, of course, that those patients seem to have lower tumor burden than the Keynote 522 population. So the value of pre versus post-operative checkpoint inhibition is unclear. And for PCR patients, particularly T1, T2 node negative, it does seem at the moment that post-operative immune checkpoint blockade benefit does seem small. And this is relevant at the moment in countries such as mine, where this treatment is not reimbursed and patients pay for an immune checkpoint blockade as part of their treatment. So if they achieve PCR, I don't at the moment see any compelling data to continue. However, for residual disease patients, it is certainly unclear the contribution of the benefit of the various pre versus post-operative administration. We may have some answers from the 2 residual disease studies, the SWOG study and evolumab study, which are looking at the administration of these agents versus placebo in patients who have neoadjuvant chemotherapy without immunotherapy and have residual disease. In the SWOG study, importantly, capecitabine is allowed. So this is at the moment standard treatment. So we'll be able to see the benefit of pembrolizumab in this setting. And this may potentially help us, if it's a positive study, understand where to give this type of therapy. One might suspect at the moment that it may be in the residual disease setting that's only the PD-L1 positive patients that might benefit if we're extrapolating from advanced disease. And, you know, in theory, if you do have residual disease, you are somewhat chemo refractory, and it seems PD-L1 refractory or resistant, and it's highly probable that you will need to add more than just post-operative checkpoint blockade. And of course, I'm thinking of some of the newer agents, such as the antibody drug conjugates. So what about capecitabine? So CREATE-X was the study which reported that a benefit of adjuvant capecitabine for patients with residual disease in the neoadjuvant setting. This was performed by the Japanese Korean breast cancer groups, and hence the population was entirely Japanese and Korean. And we know, and this is important because we know the pharmacodynamics of capecitabine differ by ethnicity, and you know, Asian populations allows for a 25% higher dose. We don't have a confirmatory trial in the same setting in another registration trial. And we need to bear in mind that this data was significant in the triple negative breast cancer subset, and this was a subset analysis of the main study. However, there are other trials in the adjuvant setting which do show the benefit of CAPE in subset analysis, particularly in the triple negative breast cancer patients. And I'm thinking here of the FIN-XX trial, there was a Roche Genentech trial and an MD Anderson study, which all reported a benefit of capecitabine, which does make sense in patients to give capecitabine where it's non-cross-reactive with or cross-resistant with the previous chemotherapy agents. The ECOG-ACRIN study looked at carboplatin versus capecitabine in patients with residual disease. This was reported as a negative study in that carboplatin was unlikely to be non-inferior or superior to capecitabine in this setting, and hence capecitabine remains the standard of care for these patients, and certainly many clinicians are prescribing capecitabine in this context, and I think this is a very reasonable thing to do. So what about patients with germline BRCA mutation? So this data comes from the Olympia study. The Olympia study had a neoadjuvant cohort or group, and this group enrolled patients with triple negative breast cancer who had residual disease post their neoadjuvant chemotherapy. Their chemotherapy was allowed to include carboplatin, but not all patients had carboplatin. And patients with residual disease were randomized to receive olaparib or placebo for 1 year. And so this is a pure residual disease study, which makes it very convenient to discuss. As from this study, it was very clear that olaparib improved invasive disease-free survival over placebo. You can see there with a hazard ratio of 0.61 and impressive 3-year absolute benefit of 8.6%. Importantly, if we look at the subgroup analysis, you can see that the benefit was the same in the adjuvant versus the neoadjuvant patients and in the triple negative breast cancer patients. So here it's very clear that patients with germline alterations who receive neoadjuvant chemotherapy they have residual disease, olaparib is an appropriate standard of care. What do we know about the immune tumor microenvironment of residual disease in triple negative breast cancer? So we know that quantity of immune infiltration has prognostic implications, which suggests that immunity still has a role to play. So we've looked at the quantity of TIL in the residual disease post-neoadjuvant chemotherapy and tried to understand the prognostic implications. And as you can see here on the left, in this particular data set, we found that particularly for patients with RCB stage 2 or stage 2 disease in residual disease, that quantity of TIL could clearly stratify patients into two prognostic groups, as seen here. So this suggests that the immune system is still active in these patients. And one could speculate that the high TIL group here has high levels of PD-L1 positivity, and perhaps this is the group that will most benefit from just the immune checkpoint blockade in this setting. However, this group here, which is an immune desert or lacks TIL infiltration, they probably will need something additional in order to try and improve their survival. And, this may be as monotherapy or in combination with immune checkpoint inhibitor. We simply don't have the answers for that at the moment. Well, we do know, however, that this TIL is predominantly T cells, as we see in early stage disease. And you can see here, if we look at this residual disease setting and the increasing level of TIL on H&E stain slides, and this correlates reasonably well to CD8 positive T cells and an increasing CD8 positive decreasing Treg ratio. So there are still T cells that are functional in the residual disease, and it suggests that the immune system still has a role to play. So what can we look further at the underlying oncogenic processes in this residual disease? So we did this a number of years ago now, where we collaborated with Justin Balco to try and understand what were the oncogenic pathways that were resulting in immune suppression. So this data set here, we looked at the TIL in the residual disease, and as you can see, the level of TIL stratifies patients nicely into groups with prognostic implications. High TIL doing much better than low TIL. We then went on to do DNA alteration profiling as well as RNA sequencing, and then group these alterations by pathway. This is at the DNA level, and I'll just highlight you to the TIL percentage on the y-axis. And you can see that patients with alterations which were reflective of activation of this pathway, yes, had on average a lower level of TIL present in their residual disease compared to patients who had no evidence of RAS-MAP kinase activation. And these patients had high level of TIL infiltration, suggesting that activation of this pathway was immune suppressive. This was also noticeable for patients with DNA repair alterations. So if you had many DNA repair alterations that were mutated in your residual disease, you had less TIL present compared to if you did not. As you can see here, again, suggesting that this process is more immune suppressive than other pathways. So can we harness these oncogenic pathways and reverse immune suppression ongoing in that tumor microenvironment? So just looking at the RNA level, and we also validated that RAS-MAP kinase was important, and you can see with increasing levels of MEK activation, you get decreasing level of TIL. So we went on then to look at what MEK inhibition was doing to the immunogenicity of breast cancer lines. And you can see here, if you treat with trametinib, which is a potent MEK inhibitor, compared with vehicle, you cause increased immunogenicity of that cell line, in that you get increased class 1 and class 2 expression over vehicle and increased PD-L1 expression on the cell, which suggests it's very rational then to combine with immune therapy treatment, which is of course what we did. And in this murine model, which was immune competent and had triple negative tumors in the mammary fat pad, we looked at the combination of trametinib and orange, and you can see that trametinib is actually quite effective in this model, but the combination with immunotherapy did better. So again, it seems that we're going to have to understand the residual disease a little bit better to try and work out the best therapies to give in these patients to try and relieve some of this immune suppression that's ongoing in these patients. So what can we conclude from the data that we currently have available? So what is our most optimal treatment of the residual disease of triple negative breast cancer patients post neoadjuvant chemotherapy and immunotherapy? Well, as I've shown you, the biology of residual disease suggests that there are oncogenic pathways that are both chemorefractory and presumably immunotherapy refractory that we are going to have to understand and work out how best to target. But what do we do now? So do patients benefit from continued post-operative immune checkpoint monotherapy, even in the neoadjuvant setting? So at the moment, we have only 2 trials, the Keynote 522 and the Gepenuevo trial. The Keynote 522 suggests that we need to give both pre and post-operatively. The German data suggests that perhaps most of the benefit is in the preoperative setting, but I think at the moment, if we can, we really don't have any choice but to give it both pre and post-operatively. In the future, you may be able to understand if this is benefiting only the PD-L1 positive population. We will hopefully, the Keynote 522 investigators will look at this. But I do think that we will probably have to, the best strategy is to combine with a new non-cross-resistant agent. For germline BRCA patients, if we move towards a new standard of neoadjuvant chemotherapy with immunotherapy and the patients have residual disease, then I think it's clear that olaparib is indicated here. Of course, Olympia did not have any immunotherapy, but there's no reason to believe that these patients would be resistant to olaparib if they receive immunotherapy in the neoadjuvant setting. So I think it's very reasonable to prescribe olaparib and continue immunotherapy if it's reimbursed. The pros of this approach is that there's possible and probable synergism. We've seen quite a bit of preclinical data suggesting that this is so. And the potential cons to this approach is that maybe there's increased toxicity and myelosuppression, and we await the safety data from the early phase studies in the advanced setting to try and understand this better. And as I've mentioned, we don't really know if both are required for benefit in everybody. And perhaps, again, maybe only the PD-L1 positive population that you need immunotherapy for, but perhaps in the PD-L1 negative population, similar to early stage disease, with the addition of olaparib, we may get some new immune activation. And for everybody else, I think it's very reasonable to consider capecitabine in patients with residual disease. Again, there's no reasons to suspect that patients would be resistant to capecitabine if they receive immune checkpoint inhibition in the neoadjuvant setting. I think it's very reasonable to combine with immune therapy if it's reimbursed. And just with the caveat that Caucasian patients need less cape dosing than Asian patients. With regards to cons of this approach, it is likely or probable or possible that we'll see some increased GI tox, and we await further follow-up with regards to the safety data from other studies, such as that from Impassion 031, and hopefully the SWOG and avelumab studies will read out in the near future to help us understand the toxicity a bit better. So we await further studies with regards to the benefit of just residual disease immune checkpoint blockade. But my personal feeling is that for patients with residual disease, we really need to prioritize new therapies in that setting. And it may be that the new antibody conjugates are going to be helpful in this situation because they contain potent and non-cross-reactive chemotherapy payloads, and combining them with an immunotherapy may be of most benefit. And as we get different ADCs, we may be able to understand which is the best chemotherapy payload to enhance or best trigger an immune response. So with that, I'd like to thank you for your attention. I hope that helped you in some way, but obviously we don't have any data at the moment. So this is all a lot of extrapolation of the data, and hopefully some of these other studies in the future will make some of the benefit of pre versus post-operative immune checkpoint blockade treatment a little bit clearer. So thank you for your attention.